My name is Gong. I'm a data scientist, data engineer. Short bullet points. I was the first data engineer at Java 5 years ago, building wearables, figuring out how do we do digital therapeutics. Wave one of that whole innovation wave. I spent last year at a company called Aspire Health in Nashville, which from a data perspective had a lot of things in common, but from a healthcare perspective was at the entire other end of the range. We were doing in-home nursing services for very sick patients, palliative care, so mostly patients in the last year or two of life. And seeing that spectrum, all of the different use cases, ethical questions, that whole milieu has been really interesting. I want to talk tonight about health tech for systems thinkers. And this is not so much about a cool application of machine learning right now. What I want to talk about is what is it going to take the kinds of innovations that we're going to hear about tonight and make those scale up across all of healthcare, not just one company here or a medical device there, but what is it going to take for all of healthcare to get that done? There's a lot of interest these days in health tech, health data, and populating that ecosystem with new ideas and innovation. I want to talk about what that's actually going to take. So when I was in high school, this book was required reading. Has anybody else in this room read this book? Okay, yeah, we've got a couple. It's thick. It's actually an interesting read if you like journalism. This is The System, and it's the epic tale of how Bill Clinton failed to get healthcare reform passed back in 1993. And the 400 pages of ins and outs on that. But the short version is Clinton came to power, thought he had a mandate, and pushed hard on the system to change. The system pushed back, and at the end of the day, Clinton lost. Give it a year, and a new guy shows up on the scene. He paid a little more attention. He actually managed to get something through. So there was no Clinton care, but we do have Obamacare. And in the last few months, we've seen another player, big, powerful guy, trying very hard to push Trump care through. So far, he has not yet got it either. Maybe he's given up for sure. I can't tell yet. But the difference is one of these three powerful people understood the system. The other two didn't. And that made all the difference. So unless you think that you are much, much more powerful and influential than Bill Clinton, Barack Obama, and Donald Trump, it behooves you to understand the system too before pushing too hard on it. Let me introduce a word that's probably not familiar. I've never heard anybody other than a doctor actually use the word iatrogenic. So you sometimes hear about iatrogenic infections, which is a polite way of saying somebody at the hospital didn't wash their hands and then the patient caught the staph infection. An even less common word is iatrocide. We're going hardcore Greek here. This is to be killed by the healer. And I raise this word because, believe it or not, in the United States, iatrocide is the third leading cause of death. There's a study last year, and this is the latest in a long series of studies documenting medical errors and the human cost of medical error. By little louder. Yeah. How's this? Yeah? Okay. I'm not going to go all the way back to the beginning. Medical error is the third leading cause of death in the United States by some estimates. Now, let me get this out of the way. There are other estimates that say, no, it's not the third leading cause of death, it's the fourth or the fifth or maybe the seventh. But no matter how you count it, accidents in hospitals, mistakes in medical billing, or mistakes in medical treatment kill hundreds of people per day. And there's a huge human toll besides just the death count. So a typical story there is something like an elderly patient is found unconscious at home, rushed to the ER, the doctors try and figure out what's going on, but they don't know the patient, there's no history, and so they make some educated guesses as fast as they can, and under pressure, sometimes they guess wrong. They make the wrong diagnosis, make the wrong treatment, and the patient passes away. Variations on that story play out hundreds of times per day. Now, I think it's a fair question, why? And what can I do to protect myself? If you go to the Agency for Health Research and Quality, this is the federal agency, recently got partially defunded, but their mandate is to help prevent this kind of thing, help understand what it is that causes medical errors, among other things. And this is really small, you probably can't read it, but I just pulled from their webpage the top 20 list of things that patients can do to protect themselves against medical error when they go into the hospital. Let me just cherry pick a few. So make sure that all your doctors know every medication you're taking. Number 3, make sure your doctors know about any allergies or adverse reactions you've had to medicine. Number 7, if you have any questions about the directions on your medicine labels, ask. Number 11, when you're being discharged from the hospital, ask your doctor to explain the treatment plan you will follow at home. So there are a few things in here about washing hands and medical treatment, but if you read this carefully, the pattern that emerges is almost all of these things are about the exchange of information. They're about making sure that the patient, the patient's family, and the doctor, and any other caregivers involved understand what's going on. So if you put on your systems thinking hat, this is not about dumb or incompetent or malicious doctors. This is about doctors who don't have the right kind of support from their IT systems. Here's the second page. Same thing plays out. It's about 80% focused on the exchange of information. And if you go to the doctor side of the equation, so here a similar 5-point list of things doctors can do, these also mostly focus on the exchange of information. So, I think when most people on the street hear medical error is the 3rd leading cause of death, they have a picture in their head, something like this. Oh, bad doctors, right? Doctors are just screwing things up. So maybe the solution here is doctors should go to more medical school. 12 years isn't enough. Or maybe the solution here is doctors should be incentivized more strongly to avoid screwing up because medical malpractice isn't enough. But I put it to you that when you look at root causes on this, when you put on your systems thinking hat, the real problem is something more like this. We have smart, motivated, talented doctors trying really hard to deliver the best care, and they're backed by really ancient information systems. So quick story. When I was at Aspire last year, we did a lot of work exchanging data with insurance companies. So we would get patient records from them that would help us to profile patients and figure out the right care plan, figure out which nurses to match patients to. And there was one insurance company that we had a bunch of struggles getting the data from, which is kind of a difficult operation to work with from the beginning. And in particular, they had contracted with us to send 2 years worth of historical data for all the patients on the system. They only sent us 1. And after some back and forth, we finally got to sit down with the IT team and they said, we'd love to share that extra data, but that's on optical tapes right now, and it would take us another month to pull that off. So they're using a data system that was built in the 70s. There have been new things bolted on since then, but the core technology is still 40-year-old technology. And that's the state of a lot of healthcare today. So if you're coming in with bright ideas for machine learning and AI, if you want to do more with software and data, you've got to understand that's what you're contending with. Health data is massively uneven. Many of the systems are very, very old, and that makes it an uphill fight if you want to deploy the latest technology. Now, fortunately, a lot of that is changing right now, and I think from a systems perspective, that's why there are so many of us in this room. People sense the changes in the air, and that's attracting a lot of talent, a lot of investment, a lot of new ideas. Quick show of hands, just to kind of gauge the audience. Who has heard or been involved in conversations around the shift to value-based care? Is that, okay, cool. Hospital consolidation, physician practice roll-ups, is this a trend that people are talking about? What about the Hollywoodization of pharma? No? Couple? No? Okay. It's big. Wow. I mean, this is almost as big for the pharmaceutical industry and clinical research as value-based care is a big deal. I don't know if it's that big, but this is also an industry-shaking trend. It's changing all kinds of things. So these are just 3 of the big things that are playing their way through the health system right now. And there are others. There are a lot of other trends if you go out and look for them. The pattern that I see that's really interesting for those of us in technology is you've got new regulation and new business models that are creating incentives for data sharing that didn't exist before. So research companies sharing more data or different data with pharmacies. Hospitals exchanging data back and forth because they're incentivized to take care of patients between visits, not just during visits. And when that happens, when you have new incentives for data sharing and also new businesses, lots of those new businesses are not satisfied with the optical drives from the 1970s. They want something new. They understand that there are better things on offer today, and they're pushing in that direction. That creates lots of new opportunities for software, data, and AI. And let's come kind of hardcore into the tech world here. 1 minute? All right. Hierarchy of needs in data science. Is this familiar? Somewhat? Yeah? Okay. What was that?
I said the new one, power plugs, but it's really emotion.
Okay, I think you're thinking Maslow's hierarchy of needs. This is the data science hierarchy of needs, which is, according to me, much, much more important. Let's play this out in the healthcare space. So healthcare right now is just getting to the point where most doctors are not using paper records anymore. In the last couple of years, we got past 90% adoption on EMRs, finally. Most of those systems do not yet really exchange data. So we've got computers, but those computers do not really talk to the internet yet. And then on top of that, we have lots of systems around analytics or workflow or business process that is starting to be built. Lots of interesting work going on here. I think the big winners 10 years from now, 5 years from now, are probably starting to show up. But the thing to understand is it's an uneven landscape. It's not as if you can go and the data will just be there. You have to think really hard about interoperability. You have to think really hard about whether your partners want to share that data with you. What's in it for them? Like why would they do it? It's a big hassle. And then we've got the guy who, I don't know what his name was in the series, but it's basically Bill Gates. And he's gonna talk CJ through, ask her a question.
No, I'm sorry. I'm just familiar with the package these days.
Well, what does the package look like these days?
You're prepared to dramatically change my standard of living if I'm prepared to sit on your board and spend an hour a month advising you on your strategic relationship with the FCC?
I don't know, that sounds like it'd be a waste of your time to me.
It does?
That's not the package.
Okay.
I'm starting a foundation because if I hold on to all this money, I start to look impolite. I want to find a single problem I can attack, something which might actually have some kind of substantive effect. Maybe I should be fighting AIDS in Africa, or maybe it's malaria. It could be clean air or election reform, I don't know. But my sense is that you would have a unique perspective on what that could be and how to make it happen.
A single problem.
It's a complicated question.
Highways is what you're looking for.
Really?
It's not sexy. No one will ever raise money for it. But 9 out of 10 African aid projects fail because the medicine or the personnel can't get to the people in need.
Infrastructure's a problem.
Blanket the continent with highways and then maybe get started on plumbing.
Also not sexy.
Makes for a lousy telethon.
A single problem. If I were going to focus on one thing in healthcare today, it would be interoperability. It would be the highways and plumbing for data. Because when that gets built out, it's going to enable the doctors to share the information that will save lives. It's going to enable the workflow tools and the analytics and the AI, all those other pieces. That's the piece that is ready to be built out now. It's the piece that it's not sexy. A lot of people don't quite understand the need yet, but it really, really matters. And that's the lever point that's going to be able to move the rest of the system. So we could recap, but I think we'll leave it there because we're a couple minutes over time. So thank you.